Welcome to Multiple Sclerosis Monthly Reports. I'm Rae-Grant, Director of Education at the Mellen Center for Multiple Sclerosis of the Cleveland Clinic. I'm the director for this activity. Pleased to introduce our speaker for this program, Dr. Pia Sormani, Professor of Biostatistics at the University of Genoa in Italy. Dr. Sormani has collaborated for many years with the Neuroimaging Research Unit at the San Raffaele Hospital in Milan, studying methodological issues related to the use of MRI in multiple sclerosis. She serves on multiple committees and editorial boards internationally, primarily in the MS field, and has been a key contributor to the study of MRI surrogate markers in MS clinical trials. Today she will tackle the topic, atrophy measures in multiple sclerosis. Do they tell us anything? Dr. Sormani.
Hi. In this presentation, we will discuss about brain atrophy measures in multiple sclerosis, and we will try to understand their clinical meaning. I will give you a brief overview of the learning objectives of this presentation. The focus will be on the role of brain atrophy as a marker of disease severity and disease progression in MS. So I will not talk about the technical details about how to measure brain atrophy, but I will be more interested in its clinical meaning. So the presentation will be divided in two sections. First, we will evaluate the prognostic value of cross-sectional measures of the volume of the brain, both over the short and the long term. And in the second section, we will evaluate the possibility to use longitudinal assessment of brain volume change, both at the group level, that is for clinical trials, and also at the individual patient level. So let's start with a brief introduction about what is brain atrophy. In this slide, we clearly see the difference between an MRI scan of a normal subject and of an MS patient. The brain of the MS patient is clearly reduced as compared to the normal one. So when we talk about brain atrophy, we mean a tissue loss. And this tissue loss can be at different levels. We can have a tissue loss in cortical or subcortical regions of the brain. We can have a Y-matter tissue loss, and everything is witnessed by ventricular enlargement. So a measurement of brain volume, from the technical point of view, is a measure of volume or a measure of volume change. In this slide, I will give you some basic concept about brain atrophy measures in MS. There are different techniques for measuring brain volume based on different approach, on different algorithms, and different procedures. The most widely used techniques in MS are the BPF, a technique that was developed by the Cleveland Clinic, and the Siena method, a method developed by the Siena University and the Oxford University. These techniques have been refined over time, and now the measurement error, especially for longitudinal measurements, is quite low. For the Siena method, the scan-rescan analysis revealed a measurement error of about 0.2% for whole brain measurement. We do know that brain atrophy measures are quite reliable measurements in group studies, that is for assessing treatment effects in clinical trials at group level, but their usefulness is not really proved for single subjects analysis. This is because we have fluctuations in the measurement caused by physiological and biological factors, and this fluctuation can confound the meaning and interpretation of the results, especially when we assess single patients. So let's start with the first section of this presentation based on cross-sectional evaluation of the volume of the brain to see whether this volume has some prognostic value in MS. In this slide, I show you the prognostic value of the normalized brain volume. NBV is for normalized brain volume, that is the volume of the brain normalized for the head size over the short term. This is an analysis run on the placebo arms of two clinical trials pulled together, the Freedoms and the Freedoms 2 studies, that were two clinical trials assessing the efficacy of fingolimod versus placebo over 2 years. But this analysis is not related to the drug. We are dealing just with the placebo cohorts, and the aim of this analysis is to evaluate the prognostic value of the volume of the brain at baseline to predict a risk of disability progression. And as you can see, if we divide these 700 patients in 3 groups according to the baseline brain volume, and we classify them as patients with a low volume of the brain, a medium volume of the brain, and high normalized brain volume, I will come back on this slide to better understand, to better explain how this classification was done. Anyway, you see that a patient with a high volume of the brain has a lower probability of progression as compared to patients with a reduced volume of the brain. Patient in the low normalized brain volume category has a probability of progression that is 36% after 2 years, as compared to an 18% in patients with the high volume of the brain. So the volume of the brain has a prognostic value over the short term, predicting the probability, a higher probability of disease progression. But we do know that brain atrophy has a prognostic value also on the long term. In this slide, we have a study published by Massimo Filippi assessing the prognostic value of gray matter volume, so the volume of the gray matter, regional estimates of brain atrophy, over 13 years of follow-up. In the first panel, you see that the baseline value of the gray matter fraction is higher in patients with a stable disease in the subsequent 13 years. Also, the baseline gray matter fraction is lower in patients who did not evolve to benign MS, but the largest difference is between patients who evolved to secondary progressive MS versus those who did not evolve to secondary progressive MS. The baseline gray matter fraction is much lower in patients that did evolve to secondary progressive MS over 13 years of follow-up. So in the next slides, we will try to focus on a different problem. We have seen that the volume of the brain has a prognostic role at the group level. So on the average, patients with a lower volume of their brain at baseline has a worse prognosis. But how can we use the volume of the brain to assess single patients? So how can we define if a patient has a low or high brain volume when we take a brain atrophy measurement on a single subject? So I will present an analysis based on a large cohort of patients that were assessed with the baseline normalized brain volume, so with the baseline MRI scan. I will try to define what is an expected volume of the brain of each patient according to his baseline characteristics. In fact, it is well known that the volume of the brain depends also on the story of the patient. First of all, on the age. We do decrease our brain with age, so older patients are expected to have a smaller brain than younger patients. But of course, patients with MS also have a volume of the brain depending on disease characteristics. So if we are able to define what is an expected volume of the brain, we can assess each patient as having a high or a low brain volume as compared to the expected volume. So let's go to some examples to better clarify this concept. In this next slide, I will show you an analysis done on a large cohort of patients. Again, we pull together 3 clinical trials, the Freedoms, Freedoms 2, and the Transforms, so collecting more than 3,000 patients. And again, we are not dealing with the effect of drugs. We're just analyzing the volume of the brain at baseline. So we have here in this first graph the distribution of the normalized brain volumes in patients enrolled in the FREEDOM study. As you can see, the average normalized brain volumes is around 1,500 cube centimeters. The same is true for the FREEDOM-2 study. The distribution of the normalized brain volumes is highly superimposed to the distribution that we have in the FREEDOM study. And finally, in the transforms, again, the distribution is well superimposed, and the average normalized brain volume is again close to 1,520 cube centimeters. So this is reassuring for pooling these cohorts together and trying to model the volume of the brain according to other baseline characteristics of the patient. And this is exactly what has been done in the subsequent slide. In this slide, we have a regression model trying to explain the volume of the brain according to other baseline characteristics. In particular, we included in this model the T2 lesion volume, that is the lesion burden at baseline, age of the patients, the baseline EDSS, the disease duration, and the sex. All these characteristics are highly correlated to the volume of the brain in a multivariate model, so they are all independent predictors of the volume of the brain. And according to these variables and to the coefficients estimated by the regression model, we are able to build a regression model estimating an expected volume of the brain. In the next slide, we have a graph comparing the expected volume of the brain with the observed one. The line represents the regression line calculated according to the regression model, showing what is the expected volume of the brain for each patient, and the red dots are the observed normalized brain volume. So according to the regression equation, we are able to classify each patient as close to his expected value or far from it. In particular, we are able to define a region in which we have patients close to their expected value, the green region in the slide. That is the region within one standard deviation from the expected value. And of course, we are able to define two regions, including patients with the volume of the brain that is much higher than expected or much lower than expected. So we have a criterion here to identify cutoffs that are patient-specific because they depend on the characteristic of each patient, to identify a patient with a high, a low, or a medium volume of the brain. So let's better explain this concept through a specific case. This is the case of Mark, who is a young patient. He was 20 years old, who has been diagnosed with MS 4 years ago. So the disease duration is quite low. His EDSS score is 1, and the T2 lesion volume is still low, around 10 cube centimeters. Mark underwent an MRI of the brain, and his brain volume resulted to be 1,530 cube centimeters. So the question is, how would you judge Mark's brain volume? And here you have 4 possible answers. The first is that it seems Mark to have a large brain volume, since his brain volume is higher than the average value we have seen in a large cohort of relapsing remitting patients. We remember that the mean of this cohort was around 1,520. Mark has 1,530, so it's higher than the average of the whole cohort. The second question is, well, it's impossible to say. The third answer is, well, taking into account Mark's profile, so age, disease duration, T2 lesion volume, and EDSS, we can say that his brain volume is low. Or the fourth answer is, well, taking into account his profile, we can say that his brain volume is high. So take the time to answer the right question, and I will show you how we can calculate and assess the Mark's brain volume. In the next slide, there's the answer. The answer can be given applying the formula we estimated to calculate the expected normalized brain volume for Mark. So we must insert into the formula the T2 lesion volume of Mark, his EDSS, his age, his MS duration, and his sex. And according to the formula, we estimate then the expected normalized brain volume for Mark is 1,603 cube centimeters. So, according again to the analysis previously shown, we would define a patient as a patient having a low normalized brain volume if his brain volume is far from the expected value more than one standard deviation. So 1,703 cube centimeters minus 68. 68 is the standard deviation of the distribution we have shown before. So the cutoff for defining a patient with the Mark's profile as a patient having a low brain volume is 1,535 cube centimeters. Mark has a brain volume that is smaller than this value, so he can be classified as a patient with a low brain volume. His brain is lower than expected, so he has some atrophy in his brain. Let's go to a second case, an opposite case. This is the case of Paul. Paul is a 60-year-old patient who was diagnosed more than 20 years ago, and now he has an EDSS of 5 and a high T2 lesion volume, let's say more than 500 cube centimeters. Again, he underwent an MRI of the brain, and his brain volume was 1,530 cube centimeters, exactly the same value as Mark. Again, let's go to the question. How would you judge Paul's brain volume? And the answer are exactly the same as the previous one. It seems to Paul to have a large brain volume because it's higher than the average. That's impossible to say. Or his brain volume is low according to his profile, or his brain volume is high according to his profile. Again, to answer this question, we must perform a calculation for Paul. And this calculation is shown in the next slide. Again, we apply the formula and we substitute in the formula the values specific to Paul. That is a high T2 lesion volume, EDSS of 5, age of 60, long disease duration, and male sex. The expected normalized brain volume for a patient with the Paul's profile is 1,377 cube centimeters. So the expected volume of the brain for such a patient is much lower than that we had for younger and more healthy patients like Mark. So we can define Paul as having a large brain volume because his brain volume of 1,530 is much larger than expected. So Paul's, even if he's older and with a longer disease duration, is not atrophic at all. Again, so I come back to the slide previously shown. This is the prognostic value of this classification. This classification assesses the value of the volume of the brain that is specific for each patient, adjusting for all the baseline characteristics. Patient with a high volume of the brain are a much better prognosis than patients with a low volume of their brain, after adjusting for all the other disease characteristics. So let's go now to the last section of this presentation that is based on longitudinal evaluation of the brain volume change. And we will do that both from the clinical trials and from single patients' perspective. Let's start with clinical trials. In this slide, I'm showing you a meta-analysis pulling together all the clinical trials lasting at least 2 years and assessing the treatment effect on brain atrophy and on disability progression. The aim of this analysis was to put into a correlation the treatment effect on MRI lesions, on brain atrophy, and on disability progression. Please note that in these graphs, we don't have the correlation between brain atrophy and disability progression, but rather the correlation between treatment effect on brain atrophy and treatment effect on disability progression. As you can see, there's a quite good correlation between the reduction on MRI lesions, the first panel, due to treatment, and the reduction in disability progression. The R-square is 0.6. Also, there's a quite good correlation between the impact of drugs on brain atrophy and the effect of drugs on disability progression. But it's interesting to note that the best correlation is obtained when we pull together, we take into account together the treatment effect on lesions and on atrophy, and we put this combined effect with the drug effect on disability progression. So this analysis tells us that we can better predict the effect of a drug on disability progression if we both take into account the effect of the drug on MRI lesions and brain atrophy. In this respect, I want to show you also in the subsequent slide a recent reanalysis that we have done. This is exactly the same figure I've shown before. The two red balls represent a sort of outliers from the regression equation. The two balls are related to the TEMSO trials. The TEMSO trials assessed the effect of teriflunomide versus placebo in a randomized trial lasting 2 years. This effect was an outlier from the atrophy regression line because in the TEMSO study there was no effect on brain atrophy, and in fact the two balls are aligned with 0 on the x-axis, but there's quite a large effect on disability progression. We included this study in the meta-analysis because the method for assessing brain atrophy was a BPS, but it was an unconventional BPS method. Recently, the TEMSO study was reanalyzed using the Siena method, and this reanalysis revealed a significant effect of the drug on brain atrophy. So including in the regression equation this reanalysis improves the correlations and make the TEMSO study no more an outlier, but the results are quite aligned with the regression equation. This is just for showing you how important is the method of assessment of brain atrophy, in that sometimes the assessment of brain atrophy can be sensitive to the method used. Finally, I'm going to show you again the role of brain atrophy as a marker of treatment response, so as a surrogate marker for disability, using an individual patient analysis. In this slide, we have again data from the FREEDOM study, so showing the effect of fingolimod on 3 surrogate outcomes, meaning that this is the effect on 3 early markers and not on disability progression, that is the final outcome of interest in this analysis. Fingolimod resulted to be effective in reducing active T2 lesions, in reducing relapses, and also in reducing the accumulation of percentile brain volume change, or the accumulation of disability over 2 years. This analysis is aimed at assessing how much of the effect of this drug on disability can be explained by the reduction in MRI lesions, in relapses, and in brain atrophy. In the next slide, we have the effect of the drug on disability. As you can see, patients treated with fingolimod had a reduction in the probability of having a progression over 2 years of about 36%. How much of this effect can be attributed to the reduction in MRI lesions, in relapses, and in brain atrophy? We run some statistical models to assess this explained effect, and in this slide we reported the proportion of treatment effect, PTE stands for proportion of treatment effect, explained by the surrogate marker on disability progression. The effect of fingolimod on MRI lesion was able to account for the 46% of the effect seen on disability progression. The effect of the drug on relapses was able to explain the 60% of the effect of the drug on disability progression. And finally, the effect of the drug on brain atrophy was able to explain only the 23% of the effect of the drug on disability progression. But interestingly, as shown in the subsequent slide, when we put all these effects in a multivariate model, it came out that the effect on MRI lesions and the effect on relapses were telling the same thing. And in fact, the effect on MRI lesion lost its significance. The two independent predictors of the effect of the drug on disability progression were relapses and brain atrophy. Putting together in a regression model both relapses and brain atrophy, it came out that the effect of the drug on these two markers was able to explain the 73% of the effect of the drug on disability progression. So these results run on individual patients was very similar to the result of the meta-analysis, saying that taking into account both the anti-inflammatory component of the effect of the drug, that is the effect of the drug on relapses, and also the effect on brain atrophy, can better explain the final effect of the drug on disability progression. And finally, in these last few slides, I will try to show you an attempt to translate the percentage brain volume change for the use in individual patients. In this study, a large cohort of relapsing remitting patients was assessed with MRI at baseline and after a follow-up of around 10 years. The same was done for a smaller cohort of healthy controls. So we have around 35 healthy controls with the volume of the brain assessed at baseline and after 10 years, and a cohort of 206 MS patients assessed over 10-12 years of follow-up. As you can see from a visual inspection, the rate of brain atrophy is higher in MS patients as compared to healthy controls, as expected. In the next slide, we have the fitted distribution of the percentage brain volume change in healthy control and in MS subjects. The aim of this analysis is to try to find a cutoff for defining what is a pathological brain volume loss, distinguishing the physiological loss of brain due to aging from a pathological loss of tissue of the brain due to the MS pathology. As you can see, the two distributions are quite superimposed on the right side. So we have many MS patients that are in the physiological range, that do not lose too much of their brain volume. But there's a distinction on the left side, meaning that there are a few healthy controls losing tissue loss at a higher rate than MS patients. So we propose a 0.4% per year as a possible cutoff for identifying a pathological brain volume loss. Of course, moving this cutoff changed the sensitivity and specificity to identify healthy controls and MS patients, but this is not the aim of this analysis. In the next slide, you have a different cutoff with a better specificity, but of course losing sensitivity. Anyway, a cutoff ranging from 0.4 to 0.5 better identify subjects that are losing their brain tissue at a higher rate than expected for normal subjects. The conclusions are related to the importance of reanalysis of clinical trial data and post-hoc analysis of longitudinal studies. In MS, we have the problem that usually we have or or we have clinical trial data that are very good quality data, but with a short-term follow-up, or we have observational data that usually are real-life data with long-term follow-up, but especially dealing with MRI, they are bad quality data. So for drawing final conclusion, for defining cutoff for brain atrophy, we will need to accumulate good quality data from large database and with long-term follow-up. And that's all, and thank you for your attention.
Thanks, Dr. Sormani, for your elegant evaluation of atrophy measures in multiple sclerosis. We know that atrophy progression is a component of the disease cascade in MS, but whether specific atrophy measures in an individual are useful in directing care still has remained complex. One of the big challenges in our field is to be able to use short-term disease change, such as MRI atrophy, to predict longer-term disability over the course of the disease. Your presentation points in a direction which may well help us with critically evaluating the benefit of our therapy, not just measured in 1 to 2 years, but in decades.